right, we're going to start off with the kidney function test, or the renal function test as it's called. And it will become pretty important, especially in all sorts of patients besides diabetics, people with kidney problems, people with stones, blood pressure, and so on. And we'll not only are we going to take a look at the routine urea, uric acid, creatinine, we are going to take a look at some other tests also. All right, so let's we'll start with the anatomy and the physiology. So the kidneys are bean-shaped organs, each the size of a fist. They are located near the middle of the back, just below the rib cage, on each side of the spine. So that is your retroperitoneal area. The kidneys are sophisticated reprocessing machines. Every day the kidney makes about 1,500 ml of urine. I hope you remember that. The waste and the extra water becomes urine, which flows to the bladder through tubes called ureters. The bladder stores urine until releasing it through the urination process. So there's a picture of your urines at the back, retroperitoneal cavity, and you've got the kidney, the ureters, the bladder, and the urethra. I always like to revise a little bit of the anatomy. Here we go. So kidney function and physiology. You can take a look at the cross section of the kidney. Right, you've got the way the kidney, fresh blood enters, the reabsorption that takes place, and the formation of the urine. So in other words, your urine is the ultrafiltrate of plasma. Okay? This is a picture in black and white. So you can take a look. You've got the cross section, and you've got the glomerulus, the Bowman's capsule. You know the blood enters through the afferent, out through the efferent. As it moves through the kidney, there's a process of exchange. As it's moving through, you've got the proximal convoluted tubule, the loop of Henle, as you can see, and the distal convoluted tubule and the collecting ducts. And as it moves along, it very probably gets rid of what is not needed, all right, through the urine. All right, you can take a look at the picture. Bowman's capsule, the afferent, the efferent, the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and so on. So we ask the question, what is renal function? We use the term renal function to talk how efficiently the kidney filters blood, right? And it is the most important function. Without that, you and I would be in trouble. People with two healthy kidneys have 100% of the kidney function. Small or mild declines in kidney function, as much as 30 to 40%, would rarely be noticeable unless it's too late, and then the problems start. Kidney function is now calculated using a blood sample and a formula to find the estimated glomerular filtration rate, the eGFR. And you can do this with certain parameters in mind. The eGFR corresponds to the percent of kidney function available. So let's take a look at that. And we will be talking about the formula to calculate it. And once you have the volume, the patient's age, height, set, weight, all that, you can feed all this data into your laptop. There's a regular calculator available and will tell you what your eGFR rate is. So let's go into causes of renal failure. Causes of renal failure are many and can be roughly divided into three groups. One, those that directly affect kidney by infection, inflammation, and upper urinary tract obstruction. Those in which there is an obstruction of the lower urinary tract. And three, systemic diseases and toxicities such as hypercalcemia, hypertension, disseminated lupus erythematosus, atheroma, and diabetes mellitus, right? So you've got kidneys. The causes may be inflammation of the upper urinary tract, those in which obstruction of the lower urinary tract, and the systemic diseases. So when and why do kidneys fail? Most kidneys diseases attack the nephrons, causing them to lose filtering capacity. Damage to the nephrons can happen quickly, often as a result of injury or poisoning. But most kidney diseases destroy the nephrons slowly and silently, and that's a silent killer as we call it. Only after years or even decades will the damage become apparent. Most kidney diseases attack both kidneys simultaneously. The two most common causes of kidney disease are diabetes and high blood pressure. People with a family history of any kind of kidney problem are also at risk for kidney disease. Others include glomerulonephritis, that's inflammation of the glomerulus, inherited kidney disease, poisons, and injury and drugs. So keep this in mind. So again, a little picture. So you've got acute kidney injury, chronic kidney disease, end-stage renal diseases. Now take a look. I think this is a picture which I give it to all my students, right? You've got the afferent arteriole which brings in blood, efferent that takes it out. You've got the glomerulus, you've got the Bowman's capsule. Then you've got, when you follow the efferent, you've got filtration, reabsorption, secretion, and excretion. So like I told you, there are some substances that are completely reabsorbed, like your sugar. In a normal person, as long as the sugar is less than 160 milligrams, you remember, everything is reabsorbed. When it goes over the renal threshold, your urine starts having glycosuria. All right. Now similarly, protein is one. Protein is not filtered. A normal urine should not contain any protein. But so when protein starts to appear, it is not a very good sign. Is it infection or is it something going wrong with the kidney itself? All right. So you've got types of renal failure. You've got acute and chronic. Acute renal failure may be classified as pre-renal, associated with poor systemic perfusion and decreased renal flow. Intrarenal, associated with renal ischemia or toxins. You know, ischemia is the blood not flowing the way it should, insufficiency. Or you have post-renal resulting from obstruction of urine flow out of the kidneys. So we have to examine what is giving it into these three sections. Chronic renal failure, so name tells you it's over time. Chronic renal failure is progressive loss of kidney function that may eventually progress to end-stage renal disease. The clinical course is described in 4 stages. The first is a decreased renal reserve with diminishing renal function but without accumulation of end products of protein metabolism. The patient has no symptoms. In the second stage, renal insufficiency, the glomerular filtration rate GFR is depressed to about 30 ml per minute and plasma chemistry begins to show abnormalities as waste products accumulate. The third stage, frank renal failure, is characterized by steadily rising serum creat and blood urea nitrogen levels accompanied by a drop in the GFR. The fourth and final stage is uremia. Levels of protein end products continue to rise. Residual urine function is less than 15% and all body systems are impaired, and that is the last stage. And then the only other alternative is kidney transplant. Take a look at the kidneys, all right? So you have the normal kidney, healthy function, proper size, low urine protein, or nothing rather. Then the diseased kidney is granular surface, decreased function, small size, high urine protein. And then take a look at the acute kidney failure. Does it look like a kidney? it looks like some ant or some animal or little cockroach has eaten it up. Look at the change in the tissues. Signs of CKD. People in early stages of CKD, that's chronic renal failure, usually do not feel sick at all. People whose kidney disease has gotten worse may need to urinate more often and less often, or less often. They feel tired, lose their appetite or experience nausea and vomiting, have swelling in their hands and feet, feel itchy or numb, get drowsy or have trouble concentrating, have darkened skin, have muscle cramps. Keep that in mind, alright. What should be done to diagnose these problems? So they say check your BP, a routine urinalysis will check for microalbumin and proteins in urine, imaging for the biopsy, blood tests will include blood urea, uric acid, creatinine, CBC, electrolytes, total proteins, albumin, calcium, phosphorus, and urine. So statin C is something new, PTH, parathyroid hormone levels, blood sugar checks, HbA1c checks, clearance tests, especially creatinine clearance, a diet to check this. All this has to be looked into. So the first parameter we study is urea. So urea is a waste product formed by the breakdown of proteins. That's where the biochemistry comes from. Urea is usually passed out in the urine. A high urea, blood urea, uremia indicates that the kidney may not be working properly, or that one is dehydrated, have a low body water content. Not a very sensitive indicator of kidney function, as it depends on water and food and is monitored by effective dialysis. Alright? So you have to be careful. Why is the urea high? Here the urea may be just high on the borderline level. Then you rehydrate the patient, the urea comes down to normal. So it's not a very, very sensitive indicator of kidney function. Alright? Creatinine. So creatinine is a waste product made by the muscles. It comes from the muscles. Creatinine passes into the bloodstream and is usually passed out in the urine. A high blood level of creatinine indicates that kidneys may not be working properly. Creatinine is usually a more accurate marker of kidney function than urea. A very sensitive indicator of kidney function, if it's secreted and is not dependent on water and food. So creatinine is not dependent on water and food like urea is. Okay? So it is a breakdown of muscle. The third parameter we look into is uric acid. So uric acid is a chemical created when the body breaks down substances called purines. So your tissues. Purines are found in some foods and drinks such as liver, anchovies, mackerel, dried beans, peas, beer, and wine. Most uric acid dissolves in blood and travels to the kidneys where it is passed out in the urine. So the body doesn't need it, it's thrown out. If the body produces too much uric acid or doesn't remove enough, one can get sick. High levels of uric acid in the body is called hyperuricemia. And here you will have patients complaining of pains in the legs, backs, etc., etc., etc. Take a look at the structures, guys, if you remember your biochemistry. The other parameter we look into is electrolytes, sodium, potassium, carbon dioxide. Potassium is controlled very carefully by the kidneys. It is important for the proper functioning of nerves and muscles, particularly the heart. Any value outside the expected range, high or low, requires medical evaluation. This is especially important if one is taking diuretic, water pill, or heart pill, digitalis, lanoxin, etc. Sodium is also regulated by the kidney and adrenal glands. There are numerous causes of high and low sodium levels, but most common levels of low sodium are diuretic usage. But doctor gives you a tablet, so you get rid of the urine regularly. So our diuretic usage, diabetes drugs like chlorampromide, and excessive water intake in patients with heart or liver disease. Carbon dioxide reflects the acid status of your blood. Low CO2 levels may be due to either to increased acidity for uncontrolled diabetes, kidney disease, metabolic disorders, or low CO2 can be due to chronic hyperventilation. The other parameter, a very sensitive one which you can monitor, microalbumin. Microscopic amounts of protein, too small to be measured, that's why it's called microalbumin. With a standard dipstick test can be early signs of kidney disease, especially in people with diabetes. Special dipsticks or laboratory tests can find microalbuminuria. So just like you have your strips for urinalysis, you can have strips for microalbumin. The American Diabetes Association guidelines recommend that anyone with type 1 or type 2 diabetes have a test called microalbuminuria at least yearly. Urine in healthy people contains less than 150 milligrams of albumin. Of course, then you've got your HbA1c, which we were familiar with in diabetes. So glucose, you monitor your glucose. Regular monitoring is required. Fasting blood sugar should be up to 100 milligram, PP about 140. The HbA1c measures your blood control, sugar control over 3 months. You will know that. According to the National Diabetic Education Program, people with diabetes should have the HbA1c tested at least once in 6 months. The levels of HbA1c should be less than 6.5%. And we've studied this in carbohydrate metabolism. Then the other parameter we look out for is albumin, serum albumin. The level of albumin in the blood is a measure of good nutrition. The research shows that people with kidney disease who become malnourished and do not get enough protein may suffer from many complications. It is especially important for people on low protein diets to have their serum protein levels measured. Normal serum albumin levels in healthy people are between 3.6 to 5 grams per deciliter. The goal of people on dialysis is an albumin level greater than 4 grams per deciliter. And guys, since it is a protein, it's measured in grams percent, remember that. And you come to CBC, and we ask ourselves, why do we do a CBC? Hemoglobin is measured as part of the complete blood count. May be measured. The kidney makes a hormone called erythropoietin, I hope you remember that controls red cell production. You can also do your total iron binding capacity, ferritin levels are also monitored. And the diagram below will tell you how it goes through. Bones and calcium in kidney function. Renal bone disease can be a serious problem for patients who have had chronic renal failure for a long time. It can cause aches, pains, and sometimes fractures. The aim is to prevent it, as treatment is much harder later. In renal failure, the calcium level of the blood becomes low and the phosphate becomes high. Keep that in mind. This imbalance needs treating, or the body overproduces parathyroid hormone in an attempt to control it, and this causes thinning of the bones. See the relationship, okay? Parathyroid hormone can increase and should be monitored in CKD. One may have to take a combination of the following. So this is your medication, alpha calcidiol or calcitriol. These are active forms of vitamin D, which is often short in renal failure as the kidney fails to process it. Phosphate binders, like you got phosphates, calcichew, and so on is also given, help to prevent too much absorption of phosphate from the gut and thus keep the levels in the blood lower. Diet may also help with this. Oh, now we've got cystatin C, maybe a new parameter for you. So cystatin C is a relatively small protein that is produced throughout the body by the nucleated cells. It is produced and destroyed at a constant rate and is found in a variety of body fluids such as blood, spinal fluid, and breast milk. Cystatin C is filtered out of the body by the glomerulus. Clusters of tiny blood vessels in the kidney that allow water, dissolved substances, and waste to pass through the walls while retaining blood cells and larger proteins. What passes through the walls of the glomeruli form a filtrate fluid. Thus, this fluid, the kidney reabsorbs cystatin C, glucose, and other substances. The remaining fluid and waste are carried to the bladder and excreted as urine. The reabsorbed cystatin C is then broken down and is not returned to the bloodstream. So try to digest this. It's a new parameter. You may have heard of it, you may not have heard of it. Okay. Significance of cystatin C, also a predictor of cardiovascular problems, besides being the kidney marker. The rate at which the fluid is filtered is called glomerular filtration rate, GFR. Decrease in kidney function leads to decrease in GFR and increase in cystatin C. Keep this relationship inverse, and waste products in the blood. Because cystatin C levels fluctuate with changes in GFR, thus there has been an interest in cystatin C test as one method of evaluating kidney function. You can take a look at the structure. Here you go. So you've got renal dysfunction, you've got genetic factors, you've got inflammation, C-reactive protein, and so on. And obesity, aging, all this leads to the production of cystatin C. Then we come to the wonderful question, what is eGFR? The person's eGFR indicator is how well the kidneys are working. An eGFR of 90 or above is considered normal. A person whose eGFR stays below 60 for 3 months or longer has CKD. As kidney function declines, the risk of complications also arise. The eGFR calculation uses the patient's creatinine measurements, keep this in mind, along with the age and values assigned for sex and race. Some medical labs may make the eGFR calculation when a creatinine level is measured and include it on the lab report. The National Kidney Foundation has determined different stages of CKD based on the value of eGFR. Dialysis or transportation is needed when eGFR is less than 15 millimeters per minute. So this is an indicator that as long as your eGFR, your filtration rate is in the vicinity of 90, it's good. If it's 60, it's a warning. Then another parameter you keep in mind, something new, NGAL. So this is neutrophil gelatinase associated lipocalcin. Is a new early marker for acute kidney disease. NGAL levels rise rapidly after renal injury and have been used in a variety of clinical situations, including intensive care, emergency medicine, renal transplantation, and procedures involving the use like IV contrast media and other nephrotoxic agents. ELISA kit does measure human NGAL in urine, plasma, and serum. The positive predictive value for acute renal failure is over 90%. ELISA can be used for the determination of human NGAL in urine, plasma, and serum as a marker for acute renal injury, which may lead to acute renal failure. So it's something new. You may have heard of it, you may not have, keep it in mind. What is GFR? The glomerular filtration rate refers to the amount of blood that is filtered by the glomeruli per minute. eGFR or GFR calculation of how efficiently the kidneys are filtering waste from the blood. So the glomerular filtration rate refers to the amount of blood that is filtered by the glomeruli per minute. Okay. So GFR indicates how much kidney function one has. It may be estimated that blood level for creatinine. If GFR falls below 30, one needs to see a kidney disease specialist. If kidney failure is confirmed, then dialysis or kidney transplant may be needed. A GFR below 15 indicates one needs to start one of these treatments. Calculators are available to calculate GFR and eGFR. Okay? So you got the normal kidney and you've got a kidney which is diseased. Alright? So what does it say? A normal kidney. I have to get my glasses on. Healthy tissue, proper size, low urine protein. Here there's a granular surface, decreased function, smaller size, high urine protein. Okay. Calculation. So creatinine clearance, when you say C, creatinine clearance is equal to urine creatinine upon plasma creatinine multiplied by 24 hours of urine volume, B. So corrected is CCR into 1.73 upon BSA. Different formulas are available, male, female, ethnic origin, and so on. Alright, so this is your parameter. 1.73 is your body surface. So creatinine clearance is calculated from the creatinine concentration in the collection of the urine sample. So what you do is, the patient is asked to collect the urine over 24 hours, and he takes it to the lab, and at that time his blood creatinine level is taken in the lab. The volume of urine is noted, and a small volume is taken aside, aliquot is taken aside, and that is monitored. So creatinine from blood, creatinine from urine is monitored. So creatinine clearance is calculated from the creatinine concentration in the collected urine sample, and urine blood flow V, and the plasma concentration PCR. Since the product of urine concentration and urine flow rate yields creatinine excretion rate, which is the rate of removal from the blood, creatinine clearance is calculated as removal per rate per minute, and the formula is there in front of you. To allow comparison of results between people of different sizes, creatinine clearance is often corrected for the body surface area, BSA, and expressed compared to the average size of a man as ml per minute per 1.73 meter cube, which most adults have a BSA which approaches 1.7. Extremely obese or slim patients should have a creatinine clearance corrected for their actual BSA. BSA can be calculated on the basis of height and weight. So that's the reason why you need to have your creatinine clearance, creatinine in urine, creatinine in blood, the height of the patient, the body weight of the patient, the sex of the patient. All this is fed into the calculator, and it will give you your clearance. The other tests that you can do are sonography, scans, biopsy. Treatment may include dialysis, hemodialysis, or peritoneal transplants. Regular monitoring of blood tests, blood pressure, and diet also very important. And you know how terrible this is. Instruments that will assay urea, uric acid, creatinine, glucose, HbA1c, microalbumin, total protein, etc. You need a semi-automated and automated system, and of course urine chemistries. So that is the end of your renal function test. I've tried to keep it very short and sweet, throwing in a few parameters for you like NGAL, for cystatin C, and so on, besides the regular urea, uric acid, creatinine. Bolo, anybody questions? Nazneen?
No, ma'am, I have no comments, but all these things we are using daily on a daily basis, EGFR calculator, everything we are using. But that NGAL concept was not new, but here it is rare.
Yeah?
NGAL.
Yeah, tell me.
We are not using here. We are not using so much use of that.
I don't think
Uh,
even in India it is used in such a great
yes, yes.
amount. I don't think so. I'm sure some of them will be doing it. But since I teach, I thought I might as well introduce something new. And all DCAs in the last 10 years are familiar with NGAL and so on. Clearance is very normal. There's nothing new to it. And cystatin C. I think people are getting
And
into
also,
that.
calculating globular nitrogen, but now globular nitrogen has become direct HA on the CI systems, these modular systems. Globular nitrogen has become a direct HA now.
Yeah.
So that is also one thing I've seen over a period of time.
Yeah, but even if you're doing urea, you divide by 2.14, you'll get your BUN.
Yes, yes.
But so we have
Sometimes
to be
when
very
I,
careful. What is your kit? If you're having a semi-automated system, find out what your kit is measuring. Or even if you have a completely automated system, or if you have a completely automated system, find out what you're doing, and then if your doctor has asked for urea, then you have to multiply it by 2.14 and give it to him. Keep that in mind.
yes. And over here, with this calculated parameters, we have a norm that every year we have to verify the calculated parameters from the list. That means we have to manually calculate the formula and verify if the report is giving the same one from the machine to the link to the our manual calculation. Means there is nothing going wrong with the link. Uh,
But
Means it's an exercise we have to do every year with all the calculated parameters, including hematology, at least the one indices, you know,
what do you calculate?
HbA1c,
What do you calculate over here?
then BDRL, this EGFR, then all the calculated parameters, kind of a thing.
Okay, your EGFR is
All, yes, yes. All the lipids also have sometimes calculated parameters. So there is an exercise we have to do every year that we have to verify that the formula is working properly in the list. That's it. So every year we have to do that exercise of checking the report, counter checking, for applying our manual formula, then getting it verified, then
who? But
HOD
you tell me,
verification.
who does this? Who is your base here? I don't think the Americans do it or the English do it. I don't think the
This
Australians do it either.
is,
ये कहाँ से लेके आए?
this is how we have, there is a standard 5189. So there is
Strange.
no direct clause on this, but
As an exercise for a
again,
student, I can understand. An exercise for a student is excellent. There's no doubt about it. But for you guys as senior techs to do this is ridiculous. Yeah, it's a waste of time.
yeah, and that also every year we have to do. The auditors want to see the calculated formula very quickly.
Maybe your accreditation may need it. Thank God we don't have something like that over here. You
From the body.
you may be asked.
From body.
Your assessor may ask you, do you know how to? And if you say yes, he says, yes, show it to me. Show it to me. Calculate and show it to me. That is possible. Huh? With the NABS, this is possible. With the CAPS also, this is possible.
SAP is also asking for the verification of the formula. Not every year, but the SAP comes every 3 years.
No, see, when they come for when they come for the audit, they will ask you. They will ask you, do you know? They will throw it at you, and you say yes. Okay, tell me. Okay, tell me. Show me how you did it. You know. So that is an exercise for the technologist who's starting off, and he or she should be taught. Are the techs taught that? You know, because I want to do a podcast. Nasreen, I want to do a podcast on medtech education today, especially in India. This guy sitting next to me, this guy, say hello to them. This Noor sitting next to me has a BWalk from Bihar. He's good. But we had to teach him everything. He's picked up very fast, there's no doubt about it. He's a very hard worker. Samajhane. And he knew nothing. Same case in Mumbai. You're charging fees of 1 lakh, lakh and a half a year at a 3-year program. Huh? So, after paying 4.5 lakhs, you know nothing. Same story because I get trainees. I get trainees. In fact, today I turned couple away. In fact, the BSc walas here in microbiology and all have started from where are they coming from? Today there's from Wilson College. Then there is from Jain. And these girls are good. There's no doubt about it. But they come to me for 2 weeks. Now what do I teach them? What do I teach them?
2 weeks.
Yeah, she says they want 2 weeks. And this girl said she's worked 2 months in the Saifi hospital.
Oh, बोले मैम का नंबर था मैंने.
No, I said no because I said let Munira come back and let her decide in January because anyway this my crew is very in a double work because Munira is not there. I go off by 3:34. This boy I put him at the 3 o'clock to 12 o'clock shift. So I've had trainees. They've come to me. In fact, Nikhat works with me. She has a B walk, and knows nothing. We've taught them everything. We've taught them everything practically. I take lectures and theory with them, and I ask them basic questions. See, till today, if I were to ask Nikhat and this boy, if I have a hemoglobin of 9 grams with an RBC count of 2 million, what is the anemia? They will scratch their heads. The basic question. RBC count of 2 million, hemoglobin of 9 grams. Hypochromic microcytic anemias, right? They will not come out with it. Or calculation of the indices. Practically they work very well. They know how to work the machines more than me. They have no problems. But a clinical interpretation is not there. I think Parul and Meena, you'll agree with me that you all clinically you knew your stuff.
Yes, ma'am.
You knew your stuff.
Yes, ma'am.
Though you're out of practical your machines or how to work it, etc., that can easily be picked up. These guys are spending 4.5 lakh rupees. Meena, what did you spend in DCA?
Ma'am, hardly anything.
Parul, what did you spend in DCA?
10 also.
Huh?
Ma'am, it was not even 10. 3.54. 4,000.
Maybe a little more. Parul, what did your batch? What
Yeah.
did you spend?
I can't remember, but it was
It'll be around 10, I think.
it can't be more.
It was under 10. I think 12. Yes. I guess, I think 5, 6, or I don't know. Don't remember.
Even I don't remember.
But it was definitely below 10,000.
And
Under
we
10,000.
and I'm telling you, we made it. We came up to 40,000 with because of the university, and they were grumbling.
Yeah.
They were grumbling, and that too in 2 installments, blah blah blah. And here they're paying 1.5 lakh every year. And
It's quite
no
different.
lectures and some silly lecture somewhere. And the girl says, "I'm going." They're teaching us accreditation. Then I ask her, "What have you learned?" I want to do a podcast. I would like Dr. Chaya Angadi. We've discussed it. Chaya was in America. She's just come back. She was hospitalized recently. We thought we'd do a podcast and put it on, asking for medtech education in Mumbai. Medtech education in Mumbai.